This is the cataract surgery, phaco in immature cataract. So this is the on table end of the surgery picture. So starting with side ports using MVR blade 180 degree apart. Little bit of intracameral lidocaine. The case is done under topical anesthesia. Air bubble. Staining the entire capsule with tryphan blue. Washing out the tryphan blue. So forming the AC with viscoelastic substance. Now doing a main port 2.8 mm. Incision at the limbus. Rhexis was started with the cystitome. A nice 5 mm rhexis was made. There was a little bit of crowding of the capsule there, so I'm taking a little more time. Would like to hold at the limbus using a forceps to stabilize the eye, as this is the very critical part of the surgery, making rhexis. So rhexis is done. Now I'm going with hydrocannula and hydrating, injecting the BSS and then gently tapping to release the trapped BSS under the lens, forming the AC with a viscoelastic substance, rotating the nucleus using Sinski hook. Patient is fairly cooperative. Now going with the phaco probe. It's not much of cortex there. Then sharp chopper. I would like to clear the air bubbles so that it doesn't hamper the visualization. Burying the probe and trying to chop. I couldn't get the hold of it, so I'm trying in a different area. Rotating the nucleus, buzzing in. That is a good chop. Rotate. Chopping again. So I don't stick to 4 quadrants. I usually do minimum 5 unless the nucleus is very soft. So around 5 to 6 is good to go. So here we can see I made around 5 parts of the nucleus here. Now changing to quadrant removal mode. The nucleus is not that hard, though it is mature cataract. I think the patient is around 60-year-old. So quadrants are removed sequentially. I'm making Ensure that the probe stays in the central safe zone. So most of the job is done by the chopper, whether it is moving the nucleus bits or bringing the nucleus bits to the phaco probe. Yeah, that's subincisional. The quadrant removal is done now. I'm going with Simcoe cannula to do cortex wash. The side port was not wide enough. It couldn't accommodate the cannula. I'm a little bit widening the side port. So here we go. Gently aspirating each clock hour. Subincisional. There I am doing little bit of anterior capsular polishing. So you can see the nice final axis, not well centered, but yeah, it's continuous, regular. In the background we can see the disc. So I'm implanting the hydrophobic IOL. I'm not extending the wound. I'm using the Simcoe cannula to form the AC, and IOL is gently rotated and placed in the bag using Sinski hook. So that's it. A little bit of washing, very minimal visco that is there over the IOL. Little bit of polishing, anterior capsular polishing. Yeah. So that's it. Gently hydrating the side ports. The IOL is well centered. The capsular axis is side port is hydrated. Again, the roof of the main port is hydrated. Intracameral moxifloxacin was injected. And that's it. Thank you for watching.